Well, welcome everybody. What an amazing number of people are joining us today. That's fantastic. Welcome to the Young Dementia Network webinar. I'm Tessa Guttridge. I'm chair of the network. Our topic today is young onset dementia and general practice. In particular, the identification of those early symptoms. Our presenters, our lovely presenters here today are Professor Marjolein de Voigt, apologies, Professor of Psychosocial Innovations in Dementia and Director of the Alzheimer's Centre, Limburg, at Maastricht University Medical Centre in the Netherlands, and then also Dr. Stevie Hendricks, postdoctoral researcher on young onset dementia and also based at Maastricht University. After the presentations, we welcome Dr. Sarah Humphreys, who's on screen right now, who will offer a general practitioner on the ground sort of perspective on this. Dr. Sarah Humphreys, GP, Associate Clinical Director for Dementia in the Bradford area and Clinical Dementia Lead for Yorkshire and Humber. Then we will have time to answer your questions. So please do post them in the Q&A function as they occur to you along the way. Do use the chat function to comment and connect with others. You're very welcome to do that. The Young Dementia Network is a community of people with young onset dementia, family members and professionals. And as such, we want to include a personal perspective. And Diana Smith-Harris, whose husband had young onset dementia, is going to offer her thoughts on why an early diagnosis is important. She's here in conversation with Catherine. If Catherine could roll the film now, please.
Okay, well, I'm really pleased today to be joined by Diana Smith-Harris. Diana cared for her husband, Eugene, who was diagnosed with young onset dementia in 2016. He sadly passed away in August 2020. Diana is a member of our Young Dementia Network steering group, and Diana was also involved with the Young Dementia Hub in Leeds, campaigning for young onset dementia to be raised on the agenda across the country. So welcome, Diana. It's really pleased to have you here with us today. And today we're going to be discussing how recognising the symptoms of young onset dementia can present a challenge to the person, to the family and to the general practitioners. And so we just wanted to ask you, why do you think it's important for us all to have a better awareness of the symptoms, the early symptoms of young onset dementia?
Yeah. Hi, Catherine. Thanks for inviting me. I think it's really important because when people are younger with young onset dementia, then it's not often recognised because they think, oh, they're depressed or they're really stressed at work, but the impact is greater because people have often been working, people have younger families. So for me, it's really, really important that it's picked up early because the impact is much greater than somebody that's older with dementia. And both for health professionals and for the general public, really, because it's not recognised. I mean, some of the groups that I'm involved in, it's been masked and people didn't recognise it was early onset dementia. So it's really, really important that people are aware of this.
Absolutely, yeah, that's true. And we've talked before about your experience with your husband and the experience you had of diagnosis. And I think for you, you said your GP did recognise the symptoms of young onset and referred you on to the memory services. But from that point, it did take a long time before he had a diagnosis. What benefits would there have been to you and your husband if you had been diagnosed earlier and the process had been quicker?
Yeah. So it took 18 months for a diagnosis, and this involved obviously the scans, the testing. I think if it had been recognised earlier, we would have been able to access the number of services that we then later found out about. Yeah. You know, we had a brilliant consultant who, when he gave the diagnosis, was very practical and said, you need to get things in place in terms of stop your husband driving, get your power of attorney in place, get your community charge discount. So we had a really practical experience, and we had a nurse in the room at the same time who then guided us through all the activities and things that were available within the Leeds area. So had we got an earlier diagnosis, we could have accessed a lot of these things earlier. And yes, it was great when we accessed them, but you know, we could have done it 18 months earlier. We really could have done. Yeah.
Yeah, and that would have made a difference for both of you.
Yes.
To not have to be waiting for that time in limbo, waiting to have it confirmed, which is something you suspected already.
That's right, yeah, because my background, I was a qualified social worker, be it that I worked with children and young people, but you've still got the same skills in terms of noticing that something was not right. You know, you still got that intuitive sort of feeling that things were not right. So to get the final diagnosis was really good. I was really pleased. And I said, right, we know what it is now. Let's move with it and build it into our lives. And that's when we got involved in lots of activities within the Leeds area.
Yeah, that's brilliant for you to have that positive experience. And it just shows what a difference it can make to have the diagnosis in that way, to the way that you both felt from that point on about it.
Yeah, and it was positive. It was a positive experience for me. It wasn't go away, as often we hear. Yes, you've got a diagnosis, go away and just live with it. We have the whole you know, package really, in terms of having a registered nurse who worked with us, that guided us. We had medication, you know, it was all really good for me.
Yeah, that's amazing to hear that experience, and really positive for us to hear that.
Yeah.
So the final question for you is, and I know you work you know, with lots of different groups trying to raise awareness of young onset. What changes would you like to see to improve the experience of diagnosis for the individual and with young onset and their family members?
I think we need to try and get a quicker diagnosis, try and get an early diagnosis as much as we can. I know at the moment the waiting lists are really high because of COVID and whatever, but I think without that, an early diagnosis, I think, will help families and carers to get that information. I think it needs to be on the national agenda, not just on the main dementia agenda. I think young onset needs to have its separate platform in terms of, you know, looking at what we can actually do specifically with young dementia, and not just put it all under one umbrella as it is at the moment with everyone who's got dementia. You're included in that, where I think we need something very specific. You know, there's been a lot of things delayed, I think, because of recent political interventions, but I think we do need a separate agenda for people with early onset dementia. Yeah,
that's it. I think that's the point there, Diana. Yeah, fabulous. Well, thank you very much for us to hear your views today. It's really, really great to hear about your positive experience and what made it positive for you and your husband. So thank you very much for sharing your experience with us.
No, thanks for inviting me. Thank you.
Thank you. Thanks then.
Isn't it? Let's move on now to our presentation from Mylin and Stevie. Thank you.
Okay, thank you. Thanks, Stevie, for sharing the presentation. Yeah, and thanks to also Diane and Catherine for a great introduction in this topic. Good to hear about also the positive experiences of Diana with the post-diagnostic support. So in the Netherlands, some years ago, 4 years ago, actually, we set up a large national study into this topic of young onset dementia. And today we will share some results of this project, and we focus mostly on the pre-diagnostic symptoms of young onset dementia in the general practice, which was also part of the PhD thesis of Stevie Hendricks that we'll present today, and who was also did a great PhD defense last Friday. So she got the doctorate degree on Friday. So congratulations again to you, Stevie, and very nice that you can present your work today in this context. So on the next slides, you see PRECODES, which stands for Prevalence, Recognition and Care Pathways in Young Onset Dementia. And this was the name of our national study. And when you go to the next slides, It shows the background of this study, as we'll already also explained from the introduction video. Well, young onset dementia occurs of course in a different life phase than late onset dementia. This also means that you have other responsibilities, different roles in life, and that brings also specific and different needs than in late onset dementia, including the need for specialized care and support. And that was also the reason to start this project. And we thought an important first step would be to define also the starting point for our project in terms of how to define young onset dementia, what term is best to use, and also in terms of age, what group do we need to include in our study. So that is the first step that we looked into in this pre-code study. And then also we wanted to find out what the incidence and prevalence is, because we often refer to very old research in this context. So I think updating the incidence and prevalence numbers is very important, also crucial information for policymakers in this field. And we looked into appropriate care, and the care pathways specifically focus on identification in the general practice. So then the overview of the project. Again, the first step was defining what is young onset dementia, then conducting a systematic review and meta-analysis to estimate the international prevalence and incidence of young onset dementia. And Stevie will show some results of this study today. We also looked into the regional prevalence in 2 catchment areas in the Netherlands, to look into also different subtypes of young onset dementia. And we contacted there all regional general practitioners, case managers, and diagnostic centers to find as many cases as possible in those regions. And we're still looking into those data currently, so we will not present that part today. We also set up a national registry in the memory clinics. So all newly diagnosed people with young onset dementia were registered here. And I will show, give an insight in some of the basic characteristics of this group that we have included up till now. And we also looked into the early recognition signs, also with the aim eventually to give more guidance to general practitioners for the early recognition of young onset dementia. So this was the overview of the project. Then first step, the definition. I will not go into detail, but just to show you our approach. First, we did an integrative review of all the literature that we could find, identifying the different terms that were used and also the different age criteria that were used and etiologies that were included. And then we used that as a basis for conducting a Delphi study. And we used the classical Delphi technique to transform opinion of experts in the fields, researchers, as well as healthcare professionals into a group consensus. And we did that by an online survey. And we had 3 rounds in this Delphi study where people had to grade statements regarding the terminology, age-related criteria, and the etiologies of dementia at young onset. We included 44 experts in the end, and these were all international experts in this field. And when you show the next slide, you can see the outcome of these consensus rounds. That consensus was reached that the preferred term would be young onset dementia. And also a moderate level of agreement was reached to prefer the age of 65 at symptom onset as the cutoff age for this group. And that means that in many studies, also in our study, we included people over 65 because of what already was told by Diana, the long delay often in the diagnosis of young onset dementia. So many people that have early symptoms have a diagnosis after 65, although the symptoms started, for example, already at 62. So this is the group that we included and looked into in our pre-code study. Then something about the National Registry. In the next slide, you will see all the clinics, the memory clinics that we included in this registry, including 7 academic centers and 40 peripheral centers. And next slide shows a kind of overview of the group that has been included so far. Over 700 people were included up till now in those 47 clinics. And yeah, what you see here is that the majority was referred by the GP, that the male-female ratio was rather equal. And the mean age at diagnosis in our group was 62. And most people presented with memory complaints in the context of the memory clinic. And 1 in 4 had already complaints for over 4 years before they were referred to this memory clinic. So we are now also looking further into the regional catchment areas, and we will continue with also this registry in the future. Yeah, I think it's very nice that we are now better able to define this group, although there are still many memory clinics not involved in the registry. So we're also still putting effort in including them, because in the Netherlands, there are currently around 90 memory clinics. So I think we've included half of them now in our register. Okay, then back to the overview, and Stevie will present her work in her PhD thesis. Stevie, the word is yours.
Thank you very much, Marjolein. So yeah, within the pre-code project, I performed my PhD research, and we looked into the prevalence and the incidence of young onset dementia, and we investigated the early recognition signs of young onset dementia in the general practice. So I'll start just a little bit about the prevalence and incidence of young onset dementia. I think these 2 things are very important to investigate, because they can give us a better indication of the burden of young onset dementia, but also help policymakers to generate enough healthcare for this special group. So that was the rationale for us to perform 2 major systematic reviews to analyze first the prevalence and then second also the incidence of young onset dementia. And both of these reviews have been published already, the prevalence in 2021 and the incidence in 2022. And I will just shortly tell you a little bit about the results that we had in these reviews. So first we will look at the prevalence, and you see here a world map. And on this world map, you can see in purple the countries that had information on the prevalence of young onset dementia. And the darker purple a country is, the more studies that were performed on the prevalence of young onset dementia. But you can still see that there are many countries that are white, and this means that these countries did not have any information on the prevalence of young onset dementia yet. So you can see here already that there's lots of knowledge gaps that we still have on the prevalence of young onset dementia. But still, we found 95 studies that had information about the prevalence. And when we analyzed these studies, we found that the overall worldwide prevalence was 3.9 million persons with young onset dementia, but this was in the age category of 30 to 65 years old. And these people already had a diagnosis before the age of 65. So we think that this is still an underestimation of the true prevalence of young onset dementia, but the most elaborate review until now. So we think that 3.9 million people is the lower bound of the true estimate of young onset dementia. We did the same for incidence. And here again, you can see the world map where we show the countries that had information on the incidence of young onset dementia. And you can see here that there are even more countries that are white. So even more countries don't have any information on the incidence of young onset dementia yet. But we still found 61 studies that did look into the incidence of young onset dementia. And when we analyzed these studies, we found that the incidence was 370,000 new cases of dementia worldwide each year. So this is quite profound, I guess. But still, as I said, with the prevalence, we think this is an underestimation of the true incidence of young onset dementia. And when we look at the group of persons with young onset dementia, as was said before, they face some different problems than older people with dementia. And one of the problems that they face is that they have a prolonged time until diagnosis. And previous research has found that there is an average diagnostic delay of almost 4.5 years between the first symptom onset and receiving a diagnosis of young onset dementia. And this is quite a long time. And there are several reasons for this prolonged time to diagnosis. So first, persons with young onset dementia can present with a large heterogeneity of first symptoms. So with elderly people, we mostly see memory complaints as first symptoms, but in young persons, it is more often changes in personality or behavior, or orientation problems, or even language problems. And many of these symptoms are not immediately related to dementia, of course, because they are very age-specific. And then second, of course, there's also the young age, because due to the young age, the persons themselves, their loved ones, but also healthcare professionals, they will not think of dementia as a potential cause for the symptoms that they are seeing. And related to that, there's also the potential misdiagnosis, because in young persons, other syndromes like depression or burnout are much more prevalent than dementia. And this means that the symptoms that the persons or the GPs are seeing are more likely associated with depression or burnout instead of dementia. And this then also leads to misdiagnosis, which can in turn lead to a delay in the diagnosis of young onset dementia. So therefore, we thought it was necessary that we recognize young onset dementia earlier, so we can potentially shorten the time until the diagnosis is made. And we thought the first step to achieve this is to investigate how the persons with young onset dementia present themselves at the general practice, so we get a better idea of the symptoms and the signs that are presented at the GP. So this was then also the aim of our study, to investigate how people with young onset dementia present themselves at the general practice up to 5 years before their diagnosis. And to answer this research question, we used the Research Network Family Medicine Primary Care Database, or RNFM in short. And this is a database from the Netherlands, and it includes information from 28 general practices from the south of the Netherlands. And these general practices have provided the patient files of over 150,000 patients anonymously for us to perform scientific research on. And we use this database to do research on young onset dementia specifically. So within the database, we found 89 persons who had young onset dementia. And in our study, the definition was that the diagnosis of dementia had to be made before the age of 70. And this was also to account for the diagnostic delay that we see in young onset dementia, as Marjolein also told us about earlier. So there were 89 persons who had a diagnosis of dementia before the age of 70. And we matched them with 162 control persons who had the same age and the same sex as the persons with young onset dementia, but who did not have dementia. And the aim was then to compare all the signs and the symptoms that they reported at the GP and compare them between these two groups. And to do this, we read the patient files of all the persons with young onset dementia from the moment of the diagnosis up to 5 years before the diagnosis. And for the control persons, we read their files from the date they were matched with the person with young onset dementia to up to 5 years before this date. And while reading all the patient files, we extracted all the ICPC codes, which are an international coding system for the GPs, and they code the symptoms and the diagnosis that they make during consultation. But we also read the written notes that the GPs wrote down during or right after the consultation, because these written notes are a little bit more elaborative, and there were some additional signs and symptoms that were noticed by the GP during the consultation that they wrote down here. And all the signs and symptoms that we found in the patient files, we categorized in these 8 different categories. And these categories we then compared between the persons with young onset dementia and the control group to see if there were any differences between these 2 groups. So we analyzed to see which categories were more common in persons with young onset dementia, but also to see at which time point they became more common. And when you look at the figure here, you can see on the right the diagnosis, and you can see all the way back to 5 years before the diagnosis. And in our analysis, we found 5 categories that were more common in persons with young onset dementia. And we found that from 5 years before the diagnosis, cognitive symptoms were more common in persons with young onset dementia compared to the control group. And adding to that, from 4 years before the diagnosis, affective symptoms were more common in persons with young onset dementia. 3 years before the diagnosis, social symptoms were more common. Then 2 years before the diagnosis, behavioral symptoms were also more common. And we saw that 1 year before the diagnosis, there was also a disturbance in daily functioning that was more common in persons with young onset dementia. So these are very broad categories that we analyzed, and also broad categories that you can see here on this slide. So I would like to give you a little bit of a better idea of the symptoms that were reported within these categories by the persons with young onset dementia. So the cognitive symptoms that were mostly reported by the young persons were forgetfulness, confusion, and language problems. And you can here already see that there's a lot of diversity in the cognitive symptoms that young persons can present with in the earlier stage of the dementia at the GP. So it's a little bit more diverse than in the elderly group. Then for the affective symptoms, we saw mostly depressive mood, anxiety, and being upset as the main symptoms that were reported at the GP. And this is a group of symptoms that is also very common in persons with depression or burnout. So here you can see where the difficulty is in distinguishing persons with young onset dementia from persons with a depression or a burnout. Then for social symptoms, we saw that they were mainly worries from caregivers who contacted the GP with their worries, work problems or relationship problems. Then for the behavioral symptoms, they were mainly changes in character, agitation and aggression. So the changes in the character were mostly changes to socially unaccepted behavior. And then finally, for the disturbances in daily functioning, we saw an overall decline in functionality. And this mainly led to people not being able to do everyday things like cooking or cleaning. But we also saw a lot of neglect, especially in self-hygiene. And we saw that there was a higher isolation, social isolation for persons with young onset dementia. What was very interesting to see in our study was that the worries from a caregiver that were expressed to the GP were actually the main trigger for the GP to refer a person for further diagnostic follow-up to a memory clinic. And I think this shows how important it is for caregivers to express their worries to the GP, but also how important it is for the GP to take these worries from the caregiver seriously. And we think this might be the first and only real specific red flag that we could identify in this study so far. Because the worries of a caregiver can give very valuable information for the GP. And I would like to illustrate this with a example of what we have read within the patient files. So there was one person who brought his daughter with him to the GP to talk about the situation that they were in. And at the GP, he did a mini mental state examination test, or MMSE, and he scored 27 out of 30 on this test. So that's quite high. And the GP also then, based on this test score, did not want to refer the person for further diagnostic follow-up. But the daughter was there, and she told the GP that she didn't think the result of the test really truly reflected the situation that they were in and the symptoms that she was seeing at home. So she was able to share some of the things that they have gone through, symptoms that she noticed with her father. And this actually changed the GP's mind, and he did refer the person to a memory clinic. And the diagnosis was established already a few months after this referral, when they first went to the memory clinic. So I think this is a good illustration of how important the worries of caregivers can be for GPs. And I think this is then also a the main red flag that we have found in our study so far. So the results of our study are a first indication that people with young onset dementia present differently to the GP, maybe already 5 years before the diagnosis. The clinical relevance of this study is still quite limited because we have looked at very broad symptom categories, and we were not able to pinpoint a lot of specific red flags, except for the one that I talked about earlier. So I think we should see this study as a first step into the earlier recognition of young onset dementia, and that there should be follow-up studies who look into different things like single symptoms. We had a very small sample size, so we were not able to look into the single symptoms, but we had to categorize the symptoms. So in future research, I think we should look at the single symptoms separately to see if there are any red flags there. And also, I think it's important to look at the longitudinal course of the symptoms, because maybe the longitudinal course of the symptoms in persons with young onset dementia may be different compared to persons with a depression or a burnout, for instance. And we could find some red flags within the longitudinal course. And last but not least, I think it's important to compare the persons with young onset dementia directly to persons with a depression or burnout. In our study, we looked at the general population as a control group, but I think in future research, it would be interesting to see if there is any difference between the persons with young onset dementia and persons with a depression, because these are the two groups that are most alike, and we would like to distinguish the persons with young onset dementia a little bit earlier. So that's what I wanted to talk to you about today. If you have any questions, I think now we have time to answer them. And I would like to give the word back to Tessa, I think.
Thank you so much. So that was packed full of information, bringing some clarity to very tricky subject, and but lots more to do, it seems. In particular, I recognize, I'm glad that you recognize the value of the family members communication with the GP and the GP listening, and that being so important. That's very interesting indeed. Rather than go straight to questions, because I can see people are adding questions as we go, I'm going to just move to Sarah and just ask Sarah to sort of comment on a few points, really, and then we will definitely leave time for questions and answers. So, Sarah, can I pose something to you if you come off, if you put your mic on? Thank you. In your experience as a GP, what's the reality that general practitioners face with young onset dementia?
I suppose the reality is that it is relatively rare, whereas things like depression that may present in a similar way are actually much more common. the other reality is that people very rarely, they're not thinking that they might have a dementia syndrome, and we're not thinking that they might have a dementia syndrome with the symptoms that they present with. So nobody's thinking of it, and so so it means that we're more likely to think about things like depression because it's common. We have this expression in England that when we hear who's behind us, think horses, not zebra, where actually we should be thinking more about the zebra, the more uncommon presentations like a young onset dementia. So that leads to greater diagnostic uncertainty because we're not thinking about dementia. And often we think about memory problems, but we don't think about some of those more subtle signs that Stevie talked about. And so we miss those. We don't ask about them, so we don't think about it.
Hence, confusion follows for people, doesn't it? And sort of added stress for the family members along the way. What part can the person and the family play with the GP to expedite the referral on for diagnosis? What part can they play?
One is keeping a bit of a diary, and for me, being able to sort of share some of those other things besides that are happening to you. What is happening to you in your life that has changed, your working problems, those changes in personality. So keeping a diary and being able to articulate some of those is one thing. Having an advocate is great. You know, you heard in the story that's bringing somebody with you that you can empower to tell somebody about those things that are going on with you. So sharing that diary and those things and getting them to think about those things. I'm going to say this though, it's really hard to do. Finding your one GP is really good. I know that's really, really difficult, and people will just say, we can't do that. But finding one person who you can get some continuity with, so that actually you can go back to them when you say, actually, it's not getting better. And the other thing is, if it still doesn't feel right and people have said it's depression and they've given you antidepressants and it's not getting better, go back. Be empowered to go back and question. And I always say to people, are you the best person to see? And what do I do if it doesn't get better? So be really clear at the end of a consultation, when should you go back if it isn't changing? And all those kind of things are probably are going to help. And you know, yeah, an advocate is often hugely important.
So that being persistent, if you know there's, you know, if you're really aware that there's concerns, and keep on going really with it. Wondering about what you feel might be helpful for to support GPs in identifying symptoms. Do you know, are there any tools, resources, training, anything that we could be developing?
I think all of those, and I know my colleague Jill Rasmussen is on the call today, and there is a great leaflet that's on your site which aimed at GPs, which talks about those myriad of other symptoms that are going on. And actually memory's a little bit of that, but it talks about changes of personality, changes of inhibition, loss of sympathy and empathy, all those behavioural things that Stevie talked about, not being able to manage money or words. So actually memory may be a small function, yet we're thinking memory dementia. What we're not thinking about is all of those other things. That leaflet is really clear, it's simple. And if we had, you know, if we could get that onto our GP systems, EMIS, System 1, and I will, you know, links to it, that will get people to think about it. And the other thing is, you know, I always say to people, if it doesn't feel right and somebody's not getting better, you need to start thinking about the zebras. You need to think about the rarer things. Start thinking, why is this person not responding in the way? So getting some of that into that training would be really useful. But yeah, all of those things you said, webinars, training resources, leaflets, all of that will really help.
Keep going with all of those. Keep
Yes, absolutely.
Yes, so if everyone looks on the Young Dementia Network site, you'll see resources, in particular the one that Sarah mentioned, which is around identifying for GPs the symptoms, but also there's a personal checklist one which kind of triggers the diary or the journal that Sarah was thinking about, which you can then as the patient you can take to your GP, and that will help you pose the difficulties that you're having with the GP. So just looking ahead, or just a quick reminder to people to pop your questions in the Q&A, because we're approaching the point where we can we'll pick them up. Just looking ahead, Sarah, considering that there are moves for earlier recognition of symptoms generally, and potential treatments coming through, hopefully. How will this affect the GP role, and in relation to young onset dementia, how do you think it will affect that role?
So I suspect we're going to be referring earlier. We're probably going to be referring more. Some of those people will have dementia and a cognitive problem, some of them won't. And there is a risk, therefore, that services get overwhelmed and that we can't cope. So I think things are going to change. And I suspect, even though I don't like the idea of people referring because of a drug, because there's so many other things that people get from a referral, I suspect that will create this sea change and greater recognition, so that more people will be referred in the future, because doctors will see it as potentially curative.
Yeah. Okay, so lots to do. I think that we have quite a number of questions, so I think it's probably best if we move to those now. But thank you very much for your comments, Sarah. I will just pull them up now. So Jill Rasmussen, Sarah mentioned Jill, hello to Jill, has asked, should there be an updated definition of young onset dementia? Is 65 years appropriate, and what other points should be considered in the definition?
Yeah, that was exactly the reason why we conducted also the Delphi study, to include the perspectives of the experts in the field around this issue. So that's why we did a survey in healthcare professionals, as well as researchers. And yeah, so the terminology in terms of using young onset dementia, everyone was quite clear about that was the preferred term to use. There was some discussion, a bit more discussion around the age at onset, because I also saw that somewhere in the chat that of course, it's kind of a definition based on the societal perspective, because it means going towards retirement age. So people, differed a bit about this, but in the end, the consensus was reached that the age of 65 years was best to use. And the other thing that you need to take into consideration when thinking about the definition is, of course, also the etiologies that you want to include. And what we saw in our study, that there was quite high consensus about the fact that Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies, Parkinson's disease, PSP, corticobasal degeneration, and Huntington's disease should be included. And then there was another category of causes that people also in the end agreed about including. So that is also something I think can differ also in terms of your goal. So in our project, we want to have also a group of people included that fit more this societal perspective, because we also wanted to look more into the impact. But I can imagine that, for example, when you are a researcher looking more into biological mechanisms, then you define it a bit smaller in terms of maybe people that have a bit more younger age, or specific etiologies that you want to include. So it's, on the one hand, important to have some kind of consensus, but on the other hand, there's also kind of this flexibility in terms of the goal that you have. I'm not sure if that's an answer to the question, but
I think you've done your best with it, and the consensus is the best, and actually the best that we can do for now. And actually, it's progress, isn't it? Because we didn't have that before. We didn't have that consensus. So
yeah, and I can imagine that maybe in the end, the cutoff age from this societal perspective will increase because people are becoming more and more active in later life stages. So maybe, yeah, in a few years' time, we reach consensus about the fact that it's better to use 70 than 65. But for the moment, this was the best consensus that we could reach.
Keep it under review then.
Yeah.
More work. Let me move on to the next question then. I am not sure of the next question. Are the symptoms similar to ADHD? Not sure how to respond on that.
I suppose the only thing to say about ADHD is that comes on a, you're not going to suddenly develop ADHD. So,
No.
So we're talking about somebody changing. So I always think thinking about change is really good when you're thinking about symptoms, and new onset symptoms are less likely to be things like ADHD.
Yeah. And from Pete Middleton, surely offering a CT scan as a routine part of initial diagnosis would identify a significant percentage of people with young onset dementia and allow medical practitioners to make more informed decisions.
Okay.
What are your views on that?
Okay, so this is probably quite a personal view, and I can see there's probably people who have different ones. I don't want GPs to refer people to scans. I want them to think about it could be dementia and refer them. And the reason is that the quality of the scan report depends on the quality of what you put on that request form. So you've got to be thinking of those types of dementia and putting that on the request form. Also, a CT might not be the right test. So you're going to waste lots of CTs when actually the person might need an MRI or a DAT scan, or even, PET scans, so some of those more, those newer type scans. So, CT scans shouldn't really, in my view, be just used as part. I don't like the idea of routine tests. And a normal CT doesn't mean that they don't have dementia, and actually could mean that they don't get referred. So I want GPs just to have a high index of suspicion, think zebra, rather than do a scan. There are the right people to do scans, and then they'll get the right scan by the right person with the right report, and it's a good history on the cards. But I can see that I suspect people will have very different views to that. But that's my personal view. Don't waste resources, use the appropriate ones.
Okay, I'm going to pick up a question because it's related to that. Do GPs routinely refer to memory clinics for assessment? People with language-led dementia, such as PPA, will usually perform well on memory, and assessment and diagnosis is further delayed. Are diagnostic clinics using the mini-linguistic state examination, modified MMSE, to pick up language-led dementia? Any comments on that question?
So in some areas, people won't go to a memory clinic. They may go to a neurology clinic under certain ages. And Tessa, you and I have discussed this, that every place has quite different pathways. So one of the things you need to know is what's your pathway at your place, depending on the age. And lots of places do that because you're more likely to have a neurological related dementia. Parkinson's and other things, the younger that a memory problem develops. And so often they don't use memory clinics. What kind of tests do people use? Well, GPs we're very much about referring through the front door. What's behind the front door and what tests they do, we're less likely to know. And lots of GPs don't actually do a full Feldstein or MMSE, because what we'll be doing is more simple tests like sit or GP cog, and what we're looking for, and a good history. Tests that are normal shouldn't stop somebody going in to be referred. That was showcased by what Stevie said. So I always say to people, if it doesn't feel right, they're telling you it doesn't feel right, but yet they score perfectly, don't worry about them. Tell the referrer, tell the clinic what it is that you're worried about, and get the family to tell you what it is. Add the narrative. Don't be stuck on tests. They're there to help you. They're not there to stop people getting into memory clinics. So a normal test that might not pick up a language difficulty shouldn't stop you referring somebody.
Good point. Good point. Thank you.
And maybe in terms of what tests to use from a research perspective, there are indications that the MoCA is in this early stage, young onset dementia, more sensitive than the MMSE, because it has a broader range of different cognitive domains that it assesses. So that's I think what I should recommend to use if you do the test.
Thank you, Mylin. What would your suggestion be if someone's partner has noticed a change in the person's presentation, but the person won't present to the GP?
Do you know that's one that we get asked a lot? Did you want to come in, Professor, before?
No, you can comment, but I guess also in terms of the study that we did, that's something that Stevie came across often, I guess, and that probably many of the partners then go to the GP themselves to express their concerns, if they're not able to motivate the person itself to go to the GP, isn't it, Stevie?
Yes, yeah, we saw that a number of times. What I saw in the patient files was that the GP did try to encourage the caregivers of the other loved ones to bring their the one that it was about, but maybe under other circumstances. So maybe not say they're here for the situation that they are in, but maybe for another complaint that they may have. And that was their way of trying to get the person with the young onset dementia to go to the GP, but it was a very difficult process if the person, him or herself, was not cooperating.
Thank you.
I would agree with everything they said. I mean, some of it is knowing why somebody doesn't want to face that. So some people will lack total insight. Others will have fear. You know, am I going to stop driving? You going to stop working? Are you going to put me in a home? So actually knowing what somebody's fears are. I would say as GPs, we're quite good at those more subtle conversations. So I would say, you know, advocates talking to us, we may not be able to divulge information, but we can listen, coming with somebody, and we're always good at getting people under pretexts, flu clinics, health checks, you name it. We can probably think of a reason to get somebody through our door to talk to, and it shouldn't stop you suffering in silence if, you know, talk to somebody.
Thank you. What about women being missed with young onset dementia, symptoms being misdiagnosed as menopause, changes in emotions, brain fog, and so on? And I think we can put a link to menopause information, menopause and young onset dementia in the chat. But have you got any thoughts about that?
Menopause is common. And the symptoms of menopause are common. So again, it's a horse, isn't it? It's a herd of horses in menopause. So it's thinking about some of those subtler signs that are less to do with menopause, I think. And it shouldn't carry on getting worse. And so it's about, so again, just like with depression, if it doesn't feel typical, mentioning it. I think the issue comes when the GP and the patient think it's menopause, only menopause, and nobody thinks of the potential for it to be a young onset dementia. But it shouldn't carry on getting worse and worse.
Did you came across this, Stevie, that people were misdiagnosed and diagnosed with menopausal complaints?
No, actually not really. In our group of patients, we didn't see a lot of complaints that were related to menopause or that were written down as being related to menopause. But I think we had a very small group of people that we looked at. So this might be something that was not prevalent in our group, but maybe something that is more prevalent in other groups that we didn't come across yet.
Yeah, maybe good to also tell that many of the things that we worked on are going to be continued in a very large consortium in the Netherlands, because we have a new dementia plan, a national dementia plan with a specific focus also on young onset dementia. And we have now a very large consortium of 6 million that can tackle many of the questions that also are raised today. So we're also looking on going to look on a larger scale into these pre-diagnostic symptoms, but also looking into, for example, what tests are most sensitive in these early stages of this young onset group, for example, to come up with better recommendations also for GPs on what to do and what not to do. So we hope maybe we can come back in a few years' time to present on that.
You'd be very welcome. Thank you. I am going to just have a quick scan of the... Did you look into any family histories, as those represent a substantial minority of young onset dementia? Did that feature?
We did see that in the patient files, that for some persons, the parents also had dementia, sometimes also even at a younger age. But this was not something that we looked into very deeply, because it was not always reported quite as well as we wish it would have been. So that was something that for this study we didn't really take into account, but it's something that we maybe in the future in our new consortium could look at more deeply and see if there is anything there that could help us as well. Yes.
Yeah, what we are going to do there is to identify the earliest symptoms of specific genetic FTD cohort and translate that to these early recognition in sporadic diseases. So it's something that we will further work on.
Thank you very much. I'm aware of the time, and we've just got a couple of minutes left. So I'm going to suggest that we pass the questions, share the questions to you after the webinar, and then if you're able to give us some very short responses, then we would be able to share those with our attendees rather than miss them completely. But we have quite a lot of questions, and I think we've had to miss some because we've run out of time. So apologies to those who posted them, and if we are able to respond, we will do. In the meantime, I just want to say a very big thank you to you. It's been a really interesting webinar. It's one of those that we've really got to look at these slides again and really got to absorb it. But thank you very much indeed for your work and for your contribution today. And I'm going to just tell you that there will be a follow-up email, and you'll have the slides and the recording and all the links to some useful resources connected with the topic. And then also to tell you that we have our next young onset webinar, Young Dementia Network webinar, which will be on the 8th of February. And that's sort of 12:30, 1:30 again. And that's young onset dementia, changing perceptions of diagnosis. And the lead presenter for that is Susan Mitchell, Head of Policy for Alzheimer's Research UK. So looking forward to that one. But for today, thank you very much indeed, all our presenters and panelists, and very much appreciate all the people who've attended. So thank you very much, and all of those participated in the chat and the Q&A. Thank you. End of webinar.